Thank you. My topic of presentation is plant-based diet and prevention of cardiovascular diseases. Coming to the cardiovascular diseases and what are the links with the diet. Cardiovascular disease is the leading cause of death globally. Poor diet is a primary risk factor contributing to high cholesterol, hypertension, and inflammation. An estimated 17.9 million people died from cardiovascular diseases in 2019, which represents 32% of all global deaths. The most important behavioral risk factor of heart disease and stroke are unhealthy diet, physical inactivity, use of tobacco, harmful use of alcohol, and hypertension. The effect of behavioral risk factor may show up in individuals as raised blood pressure, blood glucose, and lipid levels, overweight as well as obesity. Obesity and cardiovascular diseases have linked complicated mechanism which is controlled by genetic as well as environmental factors including diet. Cessation of tobacco use, reduction of salt in the diet, eating more fruits and vegetables, regular physical activity, and avoiding harmful use of alcohol have been shown to reduce the risk of cardiovascular diseases. Diet is an environmental factor which has a leading role in managing the health by preventing the obesity and the obesity related diseases, including cardiovascular diseases. Now, the question is, what is a plant-based diet? A plant-based diet focuses on eating foods primarily derived from plants, including vegetables, fruits, whole grains, legumes, seeds, and nuts, with few or no animal products. It emphasizes minimally processed food and does not have to strictly vegetarian or vegan, but rather prioritize plant sources over animal products. Now come to what are the different diets. There are basically three kinds of diets. One is vegan, which is completely elimination of animal products. Next, vegetarian diet, which excludes meat, poultry, and fish, but many individuals may include dairy as well as eggs. Next, the third one is plant-based diet, which focus on plants as a foundation, but may still include small proportion of meat, fish, or dairy. There are some key aspects of plant-based diet that what you should eat. A high intake of fruits, vegetables, legumes, whole grains, nuts, seeds, and healthy oils. Then what is the limit? Animal products, meat, dairy, eggs are eaten infrequently or in a small proportion size rather than being the main focus of the meal. Next, what we should avoid? Highly processed food, refined grains, which includes white bread and white rice, and sugary beverages. Next, what are the key components of cardiovascular benefits due to intake of plant-based diet? High consumption of plant-based food is associated with a lower risk of coronary artery disease and stroke. Research shows more or less 24% decrease in cardiovascular diseases among those following the vegetarian diet. So what we should include in our diet if we are considering the plant-based diet? That is maximum amount of fruits and vegetables, which provides essential fibers, macro and micronutrients, as well as the most important antioxidants. Then the next is whole grains, which like oats or brown rice, which are rich in micronutrients as well as fiber, which are associated with lower cardiovascular risk. Then nuts and seeds, walnuts and almonds are very rich source of omega-3 fatty acids and vitamin E. Next come to the legumes. That is the pulses. That group contains high quantity of protein as well as fibers. Next, the nutritional components, which is healthier for heart health. High fiber, which reduces cholesterol absorption and helps manage blood sugar. Potassium and magnesium, which are very essential for maintaining vascular health as well as reducing the blood pressure. antioxidant and polyphenols against which is protect against oxidative stress, improve vascular function. Plant-based omega-3, that is the alpha-linolenic acid found in flaxseed and chia seed, which supports the heart health. Health and sustainability benefits. Health, such as diet, are associated with reduced risk of chronic inflammation, obesity, and cardiovascular diseases. Sustainability, plant-based eating is recognized for having a lower environmental impact. Nutrients, diets are typically rich in fiber, vitamins, and antioxidants. So these are few photographs which can show the challenges and opportunities for implementing a heart healthy diet. So there are some challenges like compatibility of regimens with patients' lifestyles and cultural backgrounds, socio-economic status and food insecurity, as well as the availability of the healthy food options within their reach. Next, the opportunities, nutrition education in medical school as well as professional settings, using a team-based approach to prevent that incorporates a dietitian. Next, the community engagement as well as the counseling of the pupils. Next, in the another diagram, which shows that if we feed a mouse two different kinds of diets, like if we provide them a controlled diet which is completely devoid of plant foods, then we can see there is an impaired vasodilation and there is an increased vasoconstriction, as well as in the another diet that is completely inclusion of the plant-based diet, which also shows that is normalized vasodilation as well as reduced vasoconstrictions. Next, what are the mechanism of actions of plant-based diet in controlling of the cardiovascular diseases? Plant-based diets emphasizing whole grains, fruits, vegetables, legumes, nuts and seeds acts as a comprehensive preventive measures against cardiovascular diseases by simultaneously targeting multiple pathological pathways. The mechanism of action is multifaceted, involving the reduction of atherosclerotic risk factor, lowering the blood pressure, and enhancement of vascular endothelial function, primarily driven by high fiber, antioxidant, and phytosterol intake alongside low saturated fat. Number one, improvement of lipid profile, which reduce the LDL-C, lower saturated fat, replacing animal-based food with plant sources significantly lowers dietary saturated fat and cholesterol intake. Plant sterol, plant-based food contains sterol, structurally similar to cholesterol, which inhibits the absorption of dietary cholesterol in the gut. Soluble fiber, high intake of soluble fiber found in oats, beans, fruits binds to cholesterol compounds in the digestive tract, counteracting which encouraging their extraction rather than absorption, which helps lower density lipoprotein cholesterol. Second function, that is the endothelial function and nitric oxide production. The endothelial cell line blood vessels regulate vascular health. A whole food, plant-based diet can restore the ability of endothelial cells to produce nitric oxide. NO bioavailability. NO act as a vasodilator, maintaining vascular tone and preventing plaque development, preventing nitric oxide breakdown. The antioxidant and polyphenols in plants prevent nitric oxide from being broken down by the reactive oxygen species, allowing it to improve blood flow and reduce vascular inflammation. Antioxidant and anti-inflammatory effects. Chronic inflammation and oxidative stress are primarily drivers of osteosclerosis. Reduction of inflammation. Plant-based diets reduce marker of inflammation such as C-reactive protein, which contributes to the reduction of atherosclerotic progression. Phytochemicals. Abundant phytochemicals like polyphenols, vitamin C, and E act as an antioxidant that neutralize free radicals, reducing the oxidation of LDL-C. Oxidized, the LDL-C is the main culprit in driving artery damage and macrophage infiltration into the vascular wall. Number four, The blood pressure regulation. Plant-based diet significantly lower systolic and diastolic blood pressure. Potassium and magnesium. Plants are a rich source of potassium and magnesium, which promote vasodilation and help relax blood vessels. Reduce sodium. A low sodium diet is naturally achieved by eliminating processed meats and animal products, reducing salt induced vascular dysfunction. Gut microbiota modification. A diet high in fiber shapes the gut microbiome, which affect cardiovascular health. Reduced TMAO. Unlike diets high in red meat, a plant-based diet reduced the intestinal production of trimethylamine nitric oxide, a metabolite associated with promoting atherosclerosis. Metabolic control, weight and glucose. Which comes to the weight management, plant-based diet are low in energy density but high in fiber, which aids in weight loss and maintaining a healthy body mass index, thus reducing the strain on the heart. Insulin sensitivity, high fiber, nutrient dense food improve insulin sensitivity and decrease the risk of type 2 diabetes, a major risk factor for cardiovascular diseases. Next, come to the conclusion. The evidence presented in this work highlighted that plant-based diet offers a powerful multifaceted approach to reducing the burden of cardiovascular disease by emphasizing fruit, vegetables, whole grain, legumes, nuts, and seeds. Such diet lower LDL cholesterol, improve the endothelial function, reduce inflammation, regulate blood pressure, and foster a healthier gut microbiome. These mechanisms collectively contribute to improve metabolic control, weight management, and reduce risk of diabetes, key factor in cardiovascular prevention. Beyond individual health, plant-based eating also supports environmentally sustainably, making a dual benefit strategy for both humans and planetary well-being. While not requiring strict elimination of all the animal products, prioritizing plant derived food provides measurable protection against coronary artery disease and stroke, with research indicating up to a 24% reduction in incidence. Thank you.
Good day, everyone. And this will be a very recent, or we can say nascent presentation regarding environmental cardiology, which is just around 5 to 6 years old in its inception. And moreover, precision environmental cardiology, because we are going to discuss about all the omics studies, which will be helpful in doing research, which is mostly based, precision research is mostly based on diagnostics, and cardiovascular diseases are the most apt target because of the burden of the problem. So I think we can begin with the presentation, and that will be, then questions will be answered. Thank you. Good day, everyone. This is Dr. Purvashur. I'm professor of community medicine in BAMC RH, which is located in Uttar Pradesh, India. I've been acquainted with the subject of precision environmental cardiology for quite long, and I begin here by sensitizing you with the brief introduction to the subject, which is not very common in application in most of the countries yet. There is a school of thought called precision sciences or precision medicine, which includes tailor-made or personalized care which is imparted to the patient, and cardiology is one of the best targets for precision sciences because we have a lot of metabolic changes that occur in the body, and precision sciences helps us to deeply analyze the root causes with the help of genomics, metabolomics, microbiomics, transcriptomics, and other such omics studies. So let's begin with this presentation right away. But before I start, I'll just tell you that in Birmingham, there is an undergraduate course in precision medicine which takes 5 years, and there's a postgraduate course which takes up 2 years to say 4 years, part-time or full-time. And this particular precision sciences is totally engaged with diagnostics and technology-driven approach to treating patients or communities. So what will be the scheme of presentation? We'll first get acquainted with what is precision medicine, precision public health, and later on we will talk about environmental health in the context of precision sciences, because and then some research examples, and I'm working also as an advisor in Helios. So let's see what we have done with respect to precision cardiology. So precision medicine is nothing but precisely or a method of personalized treatment through analyzing genetic endowment of a particular person, his environment, lifestyle factors. It is not like one size fits all. A precise treatment and diagnostic awaits every patient who is suffering from cardiovascular diseases. But when we come to the context of environment, we would rather think about precision public health more than precision medicine. A broader protocol should be there to prevent these diseases from actually occurring in the society or in the territories. So let's see this picture, omics studies, which includes, we start from genomics. Genomics means we have the Human Genome Project, which has deciphered 20,000 genes and about 1 billion amino acid base pairs, nucleic acid base pairs, which is very important accomplishment since 2000, that is at the turn of the 21st century. And since it has been deciphered, there are more researchers using CRISPR or the tool for gene editing to understand diseases at the level of genes, as well as metabolomics or proteins that it translates into. Then the next thing that we can talk about is proteomics. These are all the proteins that are constituent in the cell or tissue. If the translation has already occurred, we will have pathological proteins that are entering into the body. If the pathological process in the gene has not begun or mutation has not occurred, it is genomics that we need to study. Epigenomics or deep phenotyping is the phenotype or the external manifestation of the proteins or the genes that are visible in the body. So I'll give you some examples on gene expression or phenotype. Transcriptomics is nothing but the most important way in which we can diagnose genetic endowment of a particular person by using mRNA splices, because here what happens is we bring about methylation of the strand of RNA, and it stops replicating or stops translating, and we can actually freeze the genome or the mRNA or the transcriptomic, because mRNA is associated with transcription, so that it occurs outside the nucleus of the cell. So when we are checking the mRNA, we will see what proteins it is translating into, and whether there are some changes or aberrations or some discordant changes that lead to pathological proteins or translation process. And then we have metabolomics, all the metabolites like substrates, enzymes, cofactors involved in cellular metabolism carried out by a proteome. These proteins or enzymes can lead to different types of metabolomes or cofactors like superoxide dismutase, lipooxygenase. All these are the metabolomics or molecular biology. It was first earlier called molecular biology. So all molecules that the cell is secreting, and that will lead to changes in the metabolism of a particular person, and it can lead to cardiac manifestations in our context. What is precision public health? That we can understand if we understand what is precision medicine. Precision medicine tells us about large or voluminous or big data, which means more information from a small population, whereas public health is a less information extracted from a larger population. Precision public health means large data or big data from a large population. That means we've taken a larger population from public health aspect and large data from precision medicine aspect. For example, all the reportings, the cardiology investigations, the lipid profile, the biomarkers that lead to understanding of the cardiac diseases, all these are the data that a person through his follow-up will keep on giving to the physician. It also includes all the CT scans or ECGs or echocardiograms, or otherwise some gadolinium-based studies or gadolinium MRI. So these are the data that an individual brings about. And if it is done for a very large population in terms of screening the person, if it is carried out for a larger population, then what we can understand is that if it is carried out for a larger population, then precision public health can be understood totally, and we can even check about the green spaces, the feasibility or access to the roads, health services, pollution in the environment. All these are factors. Or otherwise we can talk about, say, chemicals that are being introduced into the house due to the internal environment, like VOCs. For example, I'm conducting a research already on hypertension. So BP fluctuations and pulse fluctuations due to indoor pollutants, and I found that pulse is very much sensitive to pollution, and arrhythmias are one of the most common manifestations of air pollution, and especially indoor air pollution. And VOCs and particulate matter are highly are the culprits that lead to this particular association. So let's go on further with examples and understand it better. Let's come to precision environmental health as a new dimension of precision public health. Rappaport et al. Mentioned that differences in environment are responsible for 70 to 90% of diseases in human beings. For example, a young thin smoker, non-alcoholic, gets a heart attack, who upon investigation was found to be having hypertriglyceridemia with a history of low protein diet. Such patient was discovered to have hypoalbuminemia because of his low protein diet and metabolism associated fatty liver disease as the cause of his heart attack. Environmental exposures were elicited, and we found that high calorific meals that were delivered to home, sedentary lifestyle, poor walkability, sleep disruption due to light pollution in the nighttime were all responsible for, on association studies or on typically understanding the history, these were the reasons despite the patient being a thin non-smoker and non-alcoholic. So this is how we can say that, and in the genome testing we found that he had a problem or mutation or downregulation of lipid metabolizing genes. So all these factors led to this manifestation. This is how environment can help, lead to some of the diseases that are associated with some of the cardiovascular diseases that are associated with environmental health. And then with precision environmental health terminology, let us see genomics. For example, poor living conditions can cause obstructive airway disease among women using forest wood as a cooking fuel. This exposure is a non-genetic attribute of poverty. Long-term use causes mutations in priming of lungs with inheritance of pulmonary mesenchyme, which is smoke sensitive. Poor lung capacity passes on to the future generations who develop smoke intolerance. Also, upon inhalation of PM1 or PM2.5 inside their houses or in their environment above permissible levels can lead to smoke-related arrhythmias, hypertension, and other cardiovascular disease in the subsequent generations, just because it was a change in the pulmonary mesenchyme of the mother. Precision epigenomics, we can have an example like once genes have been translated to proteins, then we have to study proteins also. This is important. But if the genes have not been translated, then genome has to be studied, especially the heterochromatin, where non-coding areas are mutated and they cause methylation or changes in the histone protein, which can lead to defective cellular function, and they can cause some sort of heart disease. Then we have transcriptomics. This I earlier said that it is helpful in staging the disease, and it is also helpful in therapy. For example, if we see that there are certain changes in the microRNAs or piRNAs or tRNAs, then it can lead to hypertensive cardiomyopathy. Example is microRNA 30, which is responsible for causing hypertensive cardiomyopathy. And then we design antisense oligonucleotides. These are synthetic RNAs which are introduced into the cells through phages, and these phages can treat cardiomyopathy or prevent it from occurring if we know about the changes that are beginning to occur before there is manifestation, or we can say that before the phenotype arrives, we have already discovered what was the cause of it. Then we have proteomics, protein profiling. Obviously, there are metabolomes that, for example, 16 proteins have been discovered associated with cardiovascular diseases due to low dose mercury and lead exposures. These can be detected by gel electrophoresis, liquid chromatography, and mass spectrometry. Protein changes occur long before structural changes are visible on an ultrasound. And therefore, pollutants can also, as an example, post-translation modifications like phosphorylation and nitration can occur with the help of gaseous pollutants like VOCs, carbon dioxide, carbon monoxide. All these can lead to actin and myosin changes, and they will have changes in the physical structure of the heart. Then we have microbiomics. Firmicutes and bacteroides ratio should be good for preventing obesity and promoting cardiovascular health. It is a well-known fact, and bacteroides has a detrimental role in cardiovascular health. Although this is debatable because in some studies, bacteroides are good at maintaining heart disease. So whatever the case may be, if we have a microbial profiling of an individual, we can easily administer it through probiotics, prebiotics, and postbiotics. Prebiotics like fiber-rich diet, and probiotics like the good mycobacterium like bifidobacterium, Akkermansia. These are some of the microbes which are being studied in rats, in some other surrogates, and they found that they are quite helpful in reducing cardiovascular problems and metabolism-related diseases. And postbiotics are short-chain fatty acids like propionic acid, butyric acid that are helpful in treating people. Metabolomics, on the other hand, they are there to quantify. They function as exhausts or the end product of protein metabolism, and they're the complete readout if the cell is functioning under stressful conditions. Exposomics is the total exposome or the environment of the cell due to chemical, organic, radiological, lifestyle, green spaces, temperature, and other exposures. In totality, risk scores can be calculated, but we cannot include all the exposomes. If we include, say, out of the 13, if we are including 5 or 6, we are sure enough to find out that the person is under stress and we have to cure that person. For the omics, we need data sensing from multiple sources using deep phenotyping methods requiring high-speed technology for data storage, machine learning, and processing. Then we have the concept of envirome, interome, and pollutome. These are, interome is the bridge of the mycobacterium, and pollutome is the external myli, where inhalation and ingestion of organic and chemical compounds, built environment and social factors change genes or microbes, and ultimately this envirome leads to change to cardiological and other metabolic manifestations. Environment can be natural, social, and personal. Natural means biodiversity, lighting, storm speed, wind speed, weather, climate, altitude. Special emphasis is given to biodiversity in terms of green spaces and green landscaping that overrides with social environment. Social environment or environment lead that includes neighborhood cohesiveness, discrimination at workplace, medical help, first aid availability, insurance, and social networks. Personal means smoking, alcohol consumption, stress factors, burning of incense sticks inside houses, eating habits, etc. So precision environmental cardiology can be explained with some examples like in the multi-ethnic study of atherosclerosis, around 2,880 subjects were taken from 6 US communities for genetic studies. Proximity to roadways less than 50 meters compared to more than 150 meters was correlated with higher left ventricular mass as a predictor of heart failure, stroke, and SCD. There are other studies like Fornital explored some haplotypes or single nucleotide polymorphisms, whereby angiotensin 2, type 1 angiotensin 2 receptor and arachidonate 15 lipooxygenase genes showed 9 to 10% association with heart rate variability out of the 12 candidate genes. The normative aging study investigated 1,035 participants between 1995 to 2006, and it was found that the HRV measurements showed significant reduction due to PM 2.5 48 hours before it was the exposure, and there were mutations in genes GSTM1 and ROS. NAS study also studied black carbon, and it was associated with increased blood pressure among people showing single nucleotide polymorphisms in genes processing for microRNAs from pre or primary microRNA like DICER, Jebin4, DiGeorge, critical region 8. Then since I am working with Helios, I'll just briefly explain what we have done in terms of precision cardiology there. Helios Wellness Private Limited is a high health technology company headquartered at Infocity, Gandhinagar, Gujarat, India, as one of India's foremost IT and innovation corridors. Our founding philosophy is encapsulated in 3 words: technology, prevention, and precision. One of the pillars of precision environmental cardiology is the use of molecular markers to characterize individual cardiovascular risk with the specificity that population level statistics cannot provide. But with integrated molecular marker advisory layer in the machine learning method, we have catered to this fault. We do not wait for the patient to come to us, we bring precision to their doorstep. This is the core mission of Helios Wellness. Helios has designed its delivery model to resolve access and geographical barriers by sending a health worker team or with the health worker networks at the doorstep for diagnostics. It is a digital outreach where portable diagnostic equipment is used, and very few only censored and non-invasive techniques are used to measure, which are automatically fed through the machine learning program into the Helios platform. The language in which risk alerts, medication reminders, follow-up scheduling, and molecular marker testing guidance are delivered through these channels. And Gujarati and Hindi are used other than English as a language of discussion. Helios is building one of the India's first granular environmental cardiovascular correlation datasets, including occupational risk scores and industrial pollutant maps, with individual patient cardiovascular outcomes. Molecular biomarker profiling at population scale is also available, and Helios is generating novel insights into environmental stresses, which are modulating molecular cardiovascular risk. Then federated learning architecture and adaptive risk scoring. Here I would like to say that allowing model weights to be updated from data generated across multiple hospital partners and field sites without raw patient data after leaving the local device or facility, which means that confidentiality is one of the priorities for us. And what we do is that whatever information we have about the patient, unless it is required by the patient, it doesn't leave the facility. So it is something like intellectual property rights that are important for each hospital. The Helios cardiac risk score, our proprietary multivariable risk algorithm, is recalibrated quarterly with new data that enters the system. This is a machine learning format. As much as data we collect, as much functioning of the software happens, then there will be changes in the way we interpret the results. And we have a super ECG kind of thing, which uses non-invasive body surface sensors and patient-reported data. It performs such an analysis. 75 plus heart conditions can be detected, like arrhythmias, conduction disorders, structural abnormalities, and early subclinical changes that conventional 12-lead ECG systems routinely miss. These are some of the references that I used, and I would suggest that this is the most edgy and upcoming technology, precision public health or precision environmental cardiology. Our target is cardiology. Why we say that it has to be implemented is because in rural areas of India, we have found that cardiology patients are increasing quite a lot because of mechanization. And we have also found that it is a target for gene editing, and many of the environmental controls, if applied, this particular disease would not happen. Cardiovascular diseases, especially the coronary artery disease, will not happen for the congenital and defects that happen due to inheritance. A long way we have to go with fetal medicine, but precision medicine or precision technology is the answer to most of these problems. So I think I would stop here, and I hope the message is clear to the audience.
A very good afternoon to all of you. I am Dr. Zoya Seher. I am an anesthesiologist. I have done my MD in anesthesia and a super specialization in neuroanesthesia from Sher-e-Kashmir Institute of Medical Sciences, Kashmir. The topic which I would like to share with you all today is my study on the prevalence of serum catecholamine dysfunction in traumatic brain injury patients and its correlation with neurointensive care unit outcome and recovery. It was a prospective observational study which was conducted in our institute for a period of 2 years. So globally, the annual incidence of traumatic brain injury is variably estimated at 27 to 69 million. In India itself, it's estimated to be nearly 1.5 to 2 million. And what does this have an importance? Elevation in catecholamine level, it quantifies degree of stress. However, in traumatic brain injury, it may act as a surrogate marker of the severity, which influences the morbidity and mortality in these patients. So we hypothesized that the measurement of admission levels of serum catecholamines, may be used as an equivocal prognostic tool when compared with the admission computed tomography findings for predicting the neurological and non-neurological recovery of patients with traumatic brain injury who are admitted in the neurointensive care unit. The novelty of this study was that it was the first study of its kind, wherein we observed the correlation between the serum catecholamine levels with
Doctor,
computerized tomography.
can you translate your presentation?
Sorry?
You can see translate presentation. Open slides.
I have already.
Yes.
Is it fine?
Yes. Okay.
Okay. So shall I start from the beginning?
It's okay.
Okay. So the novelty of the study was that it was one of its kind to observe the correlation between the serum catecholamine levels with computerized tomography in patients who had mild, moderate, and severe head injury. So it was a prospective observational cohort study which was conducted at the Tertiary Care Hospital of Northern India in Kashmir, in Sher-e-Kashmir Institute of Medical Sciences for a period of 2 years. We took a proper ethical approval was taken from the Institutional Ethics Committee before the commencement of the study, and the study was also enrolled in Central Trial Registry of India. The study was also funded by the institution as an intramural project. A total of 80 patients were selected who had a clinical diagnosis of traumatic brain injury in our hospital. We included patients who were aged more than 18 years and who were diagnosed with TBI, either mild, moderate, or severe. We excluded those patients who were aged less than 18 years or the patients with medical or psychological problems which was not related to traumatic brain injury that could disturb the interpretation of results, including the drug or alcohol abuse, patients with previously known hypothalamic or pituitary dysfunction, or history of cranial irradiation or pregnancy, and those who were already on vasopressor support on arrival to hospital. So all the traumatic brain injury patients who were admitted in neurosciences ICU, they were noted for their demographic profile and any comorbidities that they had, nature of the
Doctor,
head
excuse me, please. We can see your slides.
Uh-huh.
You can open slideshow, please.
I've done it all. So can you see it now?
This is slideshow. Need a slideshow.
I did. Is it fine now? Or no?
No. Click on slideshow.
No, I have already done that. I'll again share it. Can you see?
No, doctor.
Okay, I'll just open it again.
Just.
Hello, Dr. Zoya.
Yes.
Yeah, shall we share your PPT?
Yeah, sure.
Yeah, that's great.
So how does it work? What do I need to do?
Yeah, you
Yeah,
can proceed
so,
from this slide.
okay, thank you so much. So the study was a total of, this was a prospective observational cohort study which was conducted at the Tertiary Care Hospital of Northern India in Kashmir, Sher-e-Kashmir Institute of Medical Sciences for a period of 2 years. And a proper ethical approval was taken from Institutional Ethics Committee before the commencement of the study. So this study was enrolled in a Central Trial Registry of India as well, and funding was given by the institution itself as an intramural project. So next slide, how to click. Yeah, a total of 80 patients were selected with clinical diagnosis of traumatic brain injury in our hospital. We included those patients who were of age more than 18 years and patients with traumatic brain injury, either mild, moderate, or severe. We excluded patients with age less than 18 years, those patients with medical or psychological problems not related to traumatic brain injury that could disturb the interpretation of results, including drug or alcohol abuse, patients with previously known hypothalamic or pituitary dysfunction or history of cranial irradiation or pregnancy, and those who were on any vasopressor support on arrival to hospital. Next slide. How to move the slide? So all traumatic brain injury patients admitted in neurosciences intensive care unit were noted for their demographic profile, any comorbidities, nature of head injury, imaging characteristics, and Marshall CT head classification. Baseline investigation on the day of admission in the form of complete blood count, serum urea and creatinine, liver function tests, chest radiograph, electrocardiogram, and coagulation profile was taken. And additional blood samples were sent for norepinephrine and epinephrine at the time of admissions. So on arrival of the patient to hospital, a blood sample was collected around 2 mm in a clotting tube, and the sample was transported to the immunology laboratory immediately, where it was kept at room temperature for 2 hours. And the freshly prepared serum was immediately stored in an aliquot of at minus 20 degrees Celsius for later use. And those samples, which were taken from 4 p.m. onwards, they were stored at 4 degrees Celsius overnight in the refrigerator. And then they were processed the next day in the morning at 10 a.m. and were sent to the immunology lab. So the data collection included age, gender, initial Glasgow Coma Scale, serum epinephrine, serum norepinephrine levels, the ICU mortality rate, and the Glasgow Outcome Scale score at 6 months. We assessed the outcome in the form of ICU mortality, the number of days of admission in the intensive care unit, and the number of admission days in the hospital, and Glasgow Outcome Scale. So we found that around 90 cases were enrolled in our study, including 10 controls. So we had 80 cases which were cases of traumatic brain injury, and 10 cases we took as control. Main age of patients in our study was around 41 years, and majority of them belonged to the age group of 18 to 65 years, with a male predominance of around 85%. So the most common mode of traumatic brain injury in our patient cohort was because of the road traffic accident, which was around 54%, and around 36% of the patients, they suffered fall from height, and 10% had history of assault. When we compared when we analyzed the various injuries that the patient suffered, we found that 24% of them, they suffered from the subdural hematoma, 20% had isolated extradural hematoma, and 20% had brain contusions. Mixed lesions in the form of both EDH and STH were seen in around 9% of the patients, And patients who had both subdural hematoma along with the contusions, they amounted to around 12%. And those with EDH and contusions, they were around 5%. And 5% patients in our cohort were those who had suffered from diffuse axonal injury and subarachnoid hemorrhage. In our study, we found that 46% of the patients, they suffered from severe traumatic brain injury, and 30% had moderate brain injury, and 24% had mild head injury. When we compared the serum catecholamine levels in our patients, we compared it with the controls. Those patients who we have around 10 patients which we took as controls. So we found that there was a significant increase in the serum catecholamine levels in both epinephrine and norepinephrine levels when we compared it with the control. So p-value of 0.001 was seen in both the cases. So an average of 1,077 picograms per ml of the norepinephrine levels were seen in our cases, and around 421 picogram per ml of epinephrine levels were seen in patients, while as the control we had a norepinephrine level of 130 picograms per ml and around 60 picograms per ml of epinephrine levels. So there was a huge difference between the cases and control. And when we compare these catecholamine levels based on the severity of the head injury, we found that those patients who had severe head injury, they had a significant amount of increase in the both serum norepinephrine level and serum epinephrine level, and followed by those patients who had moderate head injury, followed by those who had mild head injury. And when the Marshall CT head grading was done and the serum catecholamine levels were compared in those patients, we found that there was an increase in the serum catecholamine levels when the Marshall grading increased from grade 1 to grade 2. And there was a steep increase in the serum catecholamine levels, with highest levels found in those patients who had Marshall grade 4 grading. However, there was a paradoxically drop in the catecholamine levels in the Marshall grade 5. And as we all may be knowing that Marshall grade 5 usually are the lesions which are mixed density lesions, more than 25 cc's, like SDH or EDH, which are surgically evacuated. So we found that those patients who had a surgically isolated injury like EDH or the SDH who got operated, they had actually less amount of the serum catecholamine level surge. An ICU outcome was compared in our patients, and we found that we had an ICU mortality of around 30%. That is 24 patients from our cases, they had an ICU mortality, while as 56 patients were discharged from our ICU. Glasgow outcome scale was assessed at 6 months after the discharge, and we found that an additional 6 patients had expired. In addition to the ICU mortality, 6 patients were in addition who were found to be dead at 6 months. And severe disability was seen in around 2 patients, and moderate disability was seen in 16 patients, while as good recovery was seen in 35% of our patients. And when we compared the serum catecholamine levels in those patients who had an ICU mortality, we found that the serum catecholamine levels were grossly high in these patients, around 1800 norepinephrine levels picogram per ml, and around 763 picograms per ml of the epinephrine levels, as compared to those patients who were discharged from the ICU. And those patients who had a poor outcome at 6 months, like those who had severe disability or those who had moderate disability, they also had higher serum catecholamine levels when we compared with those patients who had a good recovery at 6 months. So TBI leads to cascade of deleterious events and activation of sympathetic nervous system, which leads to sympathetic storm or dysautonomia, which results in worsened neurological impairment and severe metabolic and systemic derangements. So long-term excitation of sympathoadrenal axes, it can lead to adverse physiological effects and can worsen the brain damage and severe head injuries. Catecholamines and the ACTH, they are increased at early stages of traumatic brain injury-related brain swelling. So these factors, they trigger hypothalamus and brainstem, which leads to increase in cerebral blood flow and can cause edema in brain and increase the brain bulk. Beta adrenoreceptors activated in the hypothalamus and brainstem locus coeruleus is subsequently dilates the cerebral blood vessels, which can itself lead to increase in the cerebral edema and can have adverse outcomes. They increase the intercapillary hydrostatic pressure, which in turn can lead to vasogenic cerebral edema. So based on the findings, it appears that the serum catecholamine levels, they can increase the cerebral edema in traumatic brain injury patients and hence can improve overall outcomes in these. And thus, these catecholamine levels, when taken care of, can improve overall outcome in these patients. By studying this relationship, we have an opportunity to target the pharmacological therapy that can prevent secondary brain injury and improve the outcome in TBI patients. The findings thereby highlights the beneficial effect of adrenergic blockade used in the acute setting of traumatic brain injury, which can in the long run improve the outcome of head injury patients. In addition, dexmedetomidine induced locus coeruleus adrenoreceptor blockade can be a potential therapy to decrease secondary brain injury, which needs further studies. So the limitations of the study were that due to limited resources, we were able to measure the serum catecholamine levels only at the time of admission to hospital, and we were not able to see the temporal relationship of these catecholamine levels over the subsequent days. So we could not determine the temporal relation. Around 30% of patients in our study population had other associated injuries like chest injury, limb injuries, abdominal injury, which may have affected the serum catecholamine levels and may have caused bias in the results. Around 40% of our patients had comorbidities like hypertension, diabetes, hypothyroidism, cardiovascular disease, and respiratory disease. Although these comorbidities were managed by supportive care, and they may have influenced the serum catecholamine levels with the possibility of bias in our study results. So we conclude that the results of this study highlight the importance of role of serum epinephrine and norepinephrine and computerized tomography grading in determining the prognosis of patients suffering from traumatic brain injury. We conclude that serum catecholamine levels measured at the time of arrival to hospital closely correlates with the computerized tomography grading, mortality, as well as 6-month outcome in patients suffering from traumatic brain injury.
Hello, dear colleagues. Let me introduce myself. My name is Evgenia Tavlueva. I'm from Moscow, from Russia. I represent our study colitis in vaccinated and unvaccinated patients with SARS COVID-19. Before I start, let me make my declaration, and I don't have conflict of interest. The aim of our study was to assess the duration and severity of colitis in vaccinated and unvaccinated patients with SARS-CoV-19. Today we know that the coronavirus pandemic is finished, but it does not mean that the coronavirus has disappeared. We diagnose several patients with coronavirus in our hospital every week. Of course, these patients don't have a severe form of coronavirus as patients in 2020, but these patients with coronavirus in 2026. Today, we have a lot of information about the coronavirus, and we know that the virus not only damage respiratory system, it can be, for example, gastrointestinal system. The virus also leads to the production of a large number of pro-inflammatory factors, such as leukocytes, This phenomenon is called a cytokine storm. Despite the changed severity of the COVID infection, vaccination issues remain relevant, considering the high number of newly infected patients in 2026. We analyzed 201 medical records in patients with coronavirus who were hospitalized from 2021 to 2022 in our hospital. The diagnosis COVID infection was made in the presence of a positive result from a laboratory study for SARS-CoV-2 RNA using a PCR test for coronavirus infection. All patients were divided into two groups. The first group was patients with who received vaccine, and the second group were unvaccinated patients. In the group unvaccinated against COVID patients, there were 23 patients with colitis. It were 22.77% patients in this group, and in unvaccinated group there were 27 patients with colitis, and it were 27% patients with colitis in unvaccinated group. Inclusion criteria were moderate COVID, signs of hyperinflammation, body temperature more than 38 degrees for 2 days or more, combined with one or more factors, such as upper level of CRP, a low level of leukocytes, and low level of lymphocytes. The diagnosis of colitis was made based on clinical and laboratory data, as well as a negative test for Clostridium difficile, and return of hypothermia, diarrhea, abdominal pain syndrome, and usually we have patients with a very hard abdominal pain syndrome and very hard diarrhea, and thickening of the colon according ultrasound data, and some of patients we did CT, and we assessed thickness of the colon wall according CT data. Exclusion criteria were severe or extremely severe COVID, the presence of pronounced laboratory abnormalities such as low level of hemoglobin, a low level of leukocyte, and a low level of platelets. Sepsis, a high change the progression of the disease to death within the next 24 hours, and previous antibiotics. Gun-COVID vac is adenovirus viral vector vaccine. It was developed in Russia by Gamaleya Research Institute of Epidemiology and Microbiology. The study included patients who provided that at least 42 days have passed since the administration of the second dose of the vaccine. So each patient had complete protection. The average time between the administration of the second dose of the vaccine and hospitalization was about 6 months. All of patients received COVID treatment. It was inhibitors for the interleukin, antiviral therapy, anticoagulants, and symptomatic therapy. We can see that patients in vaccinated group had more comorbidities. These patients were older, and these patients had more frequently respiratory disorders and heart failure. While patients in unvaccinated group had more frequently hypertension. So patients in vaccinated group were really more comorbidities. And our outcomes, we did not find statistical differences in the length of hospital between the groups overall. only 3 patients died in the vaccinated group, and only 1 patient died in unvaccinated group. In general, in the subgroup unvaccinated colitis patients were statistically more days in hospital. It was about 20 days in this group, while patients in unvaccinated and patients who does not have colitis stayed in hospital only during 9 days. And in group vaccinated patients, we received data that these patients stayed in hospital in a subgroup with colitis only 16 days, and in subgroup with no colitis only 8 days. Result in the subgroup colitis patients, we did not receive any differences in subgroup when we researched the temperature in subgroup, and the temperature in group vaccinated was 37.9 degrees, and the temperature in the group unvaccinated was 38.1 degrees. But we received a tendency towards increase in leukocyte levels in unvaccinated group, and it was 18.7, while the level leukocytes in vaccinated group was only 10.3. And the same we can see in CRP. If we see on unvaccinated group, and you can see that we have a tendency towards increasing CRP in unvaccinated group, and it was 126.4, and the level of CRP in vaccinated group was 108.8. So in conclusion, despite the high frequency of chronic disease and the medical history of the group vaccinated patients against COVID compared to the group unvaccinated patients, there were no statistically significant differences in mortality rates recorded. In cases of colitis, it was most severe in the group subgroup unvaccinated COVID patients. This is our hospital. He was located in the center of Moscow, in the beautiful part, but fortunately now it was closed. Thank you for your attention, and if you have any questions, I can answer it.
Excellent, Doctor. Thank you for the.
My name is Olga Shivaldova, and today I would like to present the results of our study on the effectiveness of comprehensive cardiac rehabilitation in adolescents with congenital heart disease. In this work, we focus not only on physiological outcomes, but also on systemic relationships between physiological, cognitive, and emotional domains. We consider rehabilitation not just as a set of interventions, but as a process that affects the entire psychophysiological system. Adolescents with congenital heart disease often demonstrate reduced heart rate variability, which is a well-known marker of impaired autonomic regulation. Reduced HRV is associated with increased cardiovascular risk, decreased adaptive capacity, and lower quality of life. At the same time, it is important to note that disturbances in this group are not limited to physiological functioning. These patients frequently experience changes in cognitive performance, including attention and processing speed, as well as emotional difficulties, such as increased anxiety and reduced well-being. All these domains, physiological, cognitive, and emotional, are closely interconnected and form a unified psychophysiological system. However, in most studies, these domains are analyzed separately, which limits our understanding of how they interact, especially in response to rehabilitation. Therefore, it becomes important to study not only individual indicators, but also the relationships between them, in order to better understand the mechanisms of recovery. The aim of our study was to evaluate the effectiveness of comprehensive cardiac rehabilitation with HRV biofeedback in adolescents with congenital heart disease. We focused on several key domains: autonomic regulation, cognitive functioning, psycho-emotional status, and, importantly, systemic relationships between these domains. We hypothesized that rehabilitation would lead not only to improvements in individual parameters, but also to adaptive reorganization of interactions within the psychophysiological system. In other words, we expected changes not only in the elements of the system, but also in the way these elements are connected. The study was conducted at the Rehabilitation Center for Children with Congenital Heart Disease at the Bakulev National Medical Research Center for Cardiovascular Surgery. The sample included 55 adolescents aged from 12 to 17 years, all in the long-term post-operative period after surgical correction of coarctation of the aorta. The rehabilitation program lasted 14 days and included several components: physical therapy with individually adjusted load, physiotherapy procedures, psychological support, and 6 to 8 sessions of HRV biofeedback. HRV biofeedback is a non-pharmacological method based on cardiorespiratory synchronization. During training, patients receive real-time feedback on their physiological signals and learn to regulate their breathing and heart rhythm. This process promotes activation of the parasympathetic nervous system and improves adaptive capacity. Before and after the rehabilitation program, a comprehensive assessment was conducted. Heart rate variability was evaluated using time domain, frequency domain, and nonlinear parameters. Cognitive functioning was assessed using the Schulte tables. This is a simple but effective method used to evaluate attention functions, including concentration, distribution of attention, and processing speed. Psycho-emotional status was assessed using the HAD scale, which measures levels of anxiety and depression, and Russian questionnaire SAN, which evaluates well-being, activity, and mood. After completion of the rehabilitation program, we observed statistically significant improvements in heart rate variability parameters. Specifically, SDNN increased, which reflects overall variability of heart rhythm. We also observed increases in VLF and LF components, as well as in total power, indicating enhanced activity of regulatory mechanisms. At the same time, approximate entropy decreased, which suggests that the physiological system became more structured and less chaotic. Taken together, these changes indicate improvement in autonomic regulation, increased parasympathetic influence, and greater stability of the physiological system. In other words, the organism demonstrates better adaptive capacity. In addition to physiological changes, we observed improvements in cognitive and emotional functioning. Cognitive performance improved, as reflected by a reduction in the time required to complete the Schulte test. This indicates improved attention, faster processing speed, and better efficiency of cognitive functioning. Psycho-emotional status also showed significant positive changes. Levels of anxiety and depression decreased according to the HAD scale, while indicators of well-being, activity, and mood increased according to the SAN questionnaire. These results suggest that rehabilitation contributes not only to physical recovery, but also to improvement of emotional regulation and overall psychological state. The most important findings of our study were obtained through the analysis of systemic correlations. Before rehabilitation, the system was characterized by numerous maladaptive relationships. In particular, we observed strong negative correlations between cognitive indicators and parameters of parasympathetic activity, as well as positive associations between anxiety and markers of stress and sympathetic activation. This pattern reflects a dysregulated and fragmented system organization, where different domains interact in a non-optimal way. After rehabilitation, we observed a clear reorganization of these relationships. Maladaptive connections were reduced, and new adaptive interactions emerged. Emotional indicators became more positively interconnected, and negative relationships between physiological and cognitive domains were weakened. This indicates a transition from a fragmented system to a more integrated and balanced organization. The results of our study suggest that rehabilitation leads to changes at the system level. The increase in HRV reflects improved autonomic regulation, while the decrease in entropy indicates a more stable and organized physiological system. At the same time, the restructuring of correlations demonstrates integration between physiological, cognitive, and emotional domains. From a mechanistic perspective, HRV biofeedback likely plays a key role. Through cardiorespiratory synchronization, it promotes activation of the parasympathetic nervous system, improves cerebral perfusion, and enhances regulation of both cognitive and emotional processes. Our findings are consistent with the concept of neurovisceral integration, which emphasizes the functional connection between the brain and the heart and considers HRV as a marker of system flexibility and adaptive capacity. In conclusion, comprehensive cardiac rehabilitation with HRV biofeedback produces multidimensional effects in adolescents with congenital heart disease. It leads to improvements in autonomic regulation, cognitive performance, and emotional well-being, and most importantly, to reorganization of systemic relationships between these domains. These findings suggest that rehabilitation should be considered not only as a method of improving individual functions, but as a system-level intervention that promotes integration and stability of the entire psychophysiological system. Thank you for your attention. I will be happy to answer.